start now. Hi, Juan.
Hi, how are you? How's
I'm
everybody?
fine, thank you. Quite interesting topic, isn't it?
Yes. Yes, it is. It's a hot topic, and it is a frequent and misunderstood topic.
Yeah, yeah. So because the area, the location of symptoms is in a very popular area in the lower quadrant, which is the inguinal area. So we have too many causes can cause symptoms in this area. But let's start thinking about from your clinical experience and the patients that you have seen before. What are the main diagnostic criteria that you consider when you say this patient could be athletic pubalgia or something else?
All right. I'm hearing that the voice is okay now.
Yeah, go ahead.
Okay. Well, the whether you're dealing with masters athletes, people 40 years and older, or professionals or teenagers, part of the problem with athletic pubalgia is that it is frequently misdiagnosed or underdiagnosed. It is thought of as a growing injury, particularly because the injury mechanism for pubalgia and for a growing injury are very similar. Typically, they involve ballistic movements. They involve more lateral movements, like in a javelin throw or ice skating or even field hockey, where people don't move necessarily on a straight line, but they say that they have pain when they say kick the ball if they're playing football. It is very common in football players because they do stretch very much the complex of the pubic area, the abdominal, lower abdominal area, and then they make a ballistic movement that is rather violent. The problem we have with pubalgia is that because most of the articles published come from abdominal surgeons, people think they'll need surgery. And unless you're a professional athlete, that's probably not the case.
Yeah. So if we go straight to the point, because I'm sure our colleagues will be quite interested to hear about the clinical practice. I would say I will give a clinical scenario, and based on that, I will say if this patient could be an athletic pubalgia or not, and then we can share the discussion. So, footballer, this patient was actually a striker, main striker in a semi-professional football team, and he used to complain from pain in the inguinal area, mainly during kicking and twisting activities. And even after the game, he can carry on with the symptoms for a good 48 hours. Even if he rests, even if he stopped training, he can feel it for a good 24 to 48 hours. So from physical examination, lumbar spine was not involved because all movements on the lumbar spine did not change the symptoms around the inguinal area. And also looking at any single leg activity was very difficult for him. Do you consider all these symptoms enough, or will be you looking for something else to confirm or to think or to put athletic pubalgia as a hypothesis?
That is an excellent start of the evaluation. It's very important, the anamnesis. We must understand the mechanism of injury. And pubalgia is a diagnosis made out of ruling out. You rule out other potential things, and typically you end up in pubalgia. You must rule out the lumbar spine, of course. You must also rule out the viscera. Viscera in the area, internal organs can certainly defer the pain, but the pain will not change no matter what you do because it's not related to movement.
Yeah.
The problem with pubalgia is diagnosed by understanding that, yes, it is in the pubic area. Yes, the patient has symptoms in the inguinal area, But no, it's not an adductor strain. It could be combined, but it's typically, it's most likely when it's pubalgia, an abdominal problem, because it is, in fact, an abdominal problem. The three layers, the deeper one transversus, the oblique, and the rectus femoris, I'm sorry, the rectus anterior, they separate. Somehow they are like this, they work together, and there's a shift. And now this shift takes away functionality and causes problems, particularly in the inguinal ring.
Yeah.
The inguinal ring is not, in general, an area where people with an adductor strain complain of. They complain rather in the insertion at the pubis and distal to that, not necessarily proximal to the pubic area.
Yeah, which make it, so in this case, you would say the location, if we think about the exact location, we might need to exclude things like the adductors. So particularly a patient with proximal adductor strain, proximal head of adductor strain, or even tear, they might produce similar symptoms. But in this case, I think one of the easy ways to exclude adductor strain is the intensity of symptoms, and also sometimes using testing like a squeezing test, adductor squeezing test, could add some value to it. Do you agree?
Actually, there is a squeezing test for the abdominal wall that is very pathognomonic of pubalgia. Let's say you have a patient lying down on their back.
Yeah.
And the patient says, well, when I lift my leg or I try to do a straight leg raise, it bothers me. That makes sense. Now, if with your hands, you put your hands on the patient's abdomen and control particularly the lower area of the abdomen, and after that, the pain goes away, well then, that takes you more to pubalgia. I'm going to get a little closer because I'm getting messages about the sound. I don't know what's wrong, but it's probably on my end.
Maybe if you got a headset or you got headphones, you might use it. Sometimes it works. If you got one. If not, that's fine.
Well, I'll keep talking. So if you contain the abdominal wall and you, with your hands, you make a kind of a corset, a manual corset, and the symptoms go away, that points much more to pubalgia than it would to an adductor or a rectus anterior strain. And in fact, it's diagnostic and it's treatment. If that works, all these tapes that we have available, particularly the elastic ones, come into play, and they can help the patient move with lesser pain. Now, explain to them that not because they have the tape, the problem is solved. Healing is healing. Biology is biology. The biology, when I worked for a while with the Chicago Bulls team physicians, the biology of Michael Jordan, myself, and Mahmoud is not very different. Mahmoud is younger, so he'll heal in 40 days. I'm older, so I'll heal in 45. And Mike Jordan has blessed genetics, so he will heal in 2. But nobody's going to heal in 20.
Right. Can I ask all of you, please, guys, just mute your microphone? That will be appreciated. Thank you. All right. So
the first thing you want to do is to minimize the strain, and then of course you have to get it stronger. Remember, you have a shift on the fascia in the different abdominal layers. So it will probably take 6 weeks for full recuperation on a patient, particularly if they're in athletics.
Yeah. So if we go, because I understand some of our colleagues they don't have massive experience with the sports athletes. Hello, can you hear me now? Yes. Yeah. All right. So what I was saying now, if we go with an ABC approach for physical examination. Just to clarify that to my colleagues, we'll definitely need to exclude lumbar spine. We definitely need to exclude adductor strain. Yeah, and thank you, you explained that very well. We might need to exclude any vascular problems around the inguinal area, maybe.
You can. In general, it doesn't give you that many symptoms. When people have an abdominal problem, they can be older than 60. So generally, they don't get hurt. But you do have to rule out viscera. The testicles could refer pain to the area. In particular, the ovaries can do that. Even the kidneys can.
Yeah, right. In terms of red flags, what are the common red flags that we might need to consider here? Definitely, we have general red flags like weight loss, constant pain, pain at night, all the generic things. But are there any other specific red flags that you'll be looking for?
In these cases, make sure the patient doesn't have an abdominal hernia.
Yeah.
So you can put your finger in the creases of the abdominal wall, have them cough, and that way rule out that this is a sports hernia versus an abdominal hernia, which will not compete us.
Yeah, yeah. And to clarify to everyone, so abdominal hernia or inguinal hernia, that's where the intestine will push the peritoneum, and then it will cause a lump, which could be easily palpable. So this, as you said, these are red flags that we need to consider, because in this case, if it's an inguinal area, it's not our rule. It has to be surgical rule in this case, or to be non-physiotherapy. Okay. So so this in terms of physical examination. There's a couple of studies that I came across in 2016, and guys, you'll find this the reference list on the website anyway, that made some link between limited hip range of movement and the incidence of athletic pubalgia. So that's mean in our clinical examination, we must definitely consider active and passive range of movement of the hip joint. And also they considered poor internal and external rotation control around the hip and the pelvic area. That's mean we might need to assess the control, the rotation control around the hip. Juan, it's a bit confusing these days because people assess movement in different ways. So if I ask someone with a sports background, how could you assess the internal rotation and external rotation control around the hip? He might do it in different way from someone who works with Pilates population, for example. How do you do it? How do you assess rotation control?
Well, the fact is we must address anterior hip flexibility.
Yeah.
Many people, more so in the Western world, have Okay, hi. So we address anterior hip tightness. Many people, particularly in the Western world, have anterior tight hips. And if the anterior tight hips are tight, particularly in athletes, not only will they be prone to injury, but also the athletic performance gets decreased because they cannot gain those 15 or so degrees of hip extension that they will need in sprinting and acceleration. Now, if the patient has restricted extension because of a tight anterior hip, then the probabilities of adding strains to the area, like the lower abdominal muscles, is higher. And they will try to compensate, but they won't be able to do it because the anterior hip is so strong. So we must address this problem. And if the patient gets better from the pubalgia, but we don't address the flexibility of the anterior hip, that person will go back into exactly the same problem. The rotations, particularly internal rotation, goes along with the flexibility of the anterior hip capsule. So we must make sure that the rotation is even. Frankly, we can talk about degrees, but people are different, and the best comparison is with the opposite limb. See if they have flexibilities that are matchable. If there is a big difference between external and internal or right and left, then that's your problem.
Yeah. So based on that, so we have in our assessment we have the movement component where we must assess the range of movement, lumbar spine and hip. We have the muscle or tissue flexibility component, and as you recommended, anterior hip flexibility is a key. And then we have the control component where we must assess the control of hip rotation. And I think there is a very popular test that has been stated by Charlie Sermon, I think in 1995, which is a hip rotation test, where the patient will be lying in crook-lying position, and then he will start to control hip external rotation without causing any movement around the pubic area or around the ilium area, which if the patient can do that, that's mean he passed the test. If he couldn't do it, we can use the same test as an exercise. All right. So so it looks like we covered the key points in physical examination, but something that has been mentioned on the literature, which is leg length discrepancy, and how leg length discrepancy could be a risk factor. Shall we advise our colleague to consider leg length measurement as a key in case if they have any doubt of leg length discrepancy? Because in this case, we have a risk factor that's going on, and without considering shoe insole or any other similar approach, we might end up with overloading of the pubic area and overloading of the groin area, and we'll have reoccurrence of the problem. So any comments on that? Have you
yes, if there is a significant leg discrepancy, that could add to the problem, but don't get very obsessed with it.
Yes.
Remember that the patient has had this discrepancy, if it's there, for a while.
Yeah.
So you are dealing with a compensated system, unless you're talking about a teenager whose parents tells you that the kid grew 8 centimeters in the past 3 months.
Yeah.
But other than that, the system is compensated. If the difference is less than 1 centimeter, ignore it. It means 0.
Yeah.
That is not going to be adding to the problem. Now, if it is very significant, if you have 2 centimeters, then the patient probably knows that, and they may come in with a shoe insert, which will give you the idea that this is a problem.
Yeah.
As a general rule, there's more trouble with lack of stabilizers, like weakness of the lower abdominal wall and or weakness of the gluteus medius, than there is the problem with leg discrepancy.
Yeah. Yeah. So in this case, I'm totally agree. We shouldn't be obsessed with leg length discrepancy because there's no one in the population is fully symmetrical. So yeah, we should expect this kind of tiny variation. So I'm a slow learner. So guys, I'll just summarize everything again. So we looked at common symptoms in subjective examination in terms of location, in terms of patient complaint. And then we discussed physical examination. We looked at range of movement, motor control, flexibility, if needed, leg length discrepancy. And then let's move to decision making. Keep or refer. What are the criteria from your point of view, Juan, that make you say, no, this patient has to go for physio? Because on the literature, it looks like there's some sort of agreement that we need to try conservative treatment first for a good 6 to 12 weeks before we decide if the patient goes to surgery or not. How do you feel? How do you think about that?
That's a very good question. And that comes along with the level of competition.
Yeah.
If we're talking about professionals, if we're talking about professional athletes or somebody that is going to Tokyo now next year, that's one management. For everybody else, we should try. We should try because chances are it's going to get better, and we can analyze it and explain to the patient, look, this is not a 45-degree angle. This is a Gauss curve. It will get better from week 3 to week 6. That's the way it works. And for the majority of the cases, even people who are competitive, they will get very good results with physiotherapy and recover and return to the prior level of function. It is very easy for me to go back to my prior level of function because at 85% of my maximum, I operate perfectly well. That is not the case with a decathlete that's going to Tokyo. That decathlete cannot operate at 85%.
Yeah.
So those cases where we should consider that maybe this patient requires surgery will be very obvious because they represent less than 1% of the population. Actually, they represent 0.6% of the population.
Yeah.
And they are the people that go to the Olympic Games. They are the people who play professional football, who play professional basketball. And those do have a set of different rules for calling them somehow, partially because of the level of intensity that they require, and partially because of money. For them, not being able to compete represents a serious economical burden, and they could lose a contract, and there are other factors in play. It's not that the morale is different, but someone like me can wait 6 months, and so what? A professional athlete may not be in that position. This also applies in the military, particularly with special forces that do the same thing over and over again. Soldiers are athletes. It's the same clinical classification. And they need to be able to carry equipment, walk with boots that are not the best for athletics, but they are the ones they need. And they typically get into situations that are very unpredictable.
Yeah, yeah. So that's mean our role as a physios is quite important with these cases, because if we look at the category of clients or customers that you just mentioned, I would say you might be dealing with 95% of these customers. That's mean, yeah, that's mean because people work with immature footballers, semi-professional or non-professional league. So you will face such cases, and even at younger age. So one of my cases was actually 17. It's nice to have this kind of clinical skills of examination and rehab for such condition. So we can, I think our colleagues, they definitely start to guess what could be the rehab process for these cases. Because if we talked about the common problems associated with this condition, which is limited movement, poor or limited control around the hip and pelvis, regaining balance between adductors and abductors, they can definitely start thinking about what shall we do. We need to keep the mobility level high. Would you recommend that for the hip? Yeah.
You can do it, but there are, like, the example you mentioned is excellent, because in teenagers, particularly when they're growing,
Yeah.
you get this kind of situation.
Yeah. Yeah. So mobility is a very important element of the treatment. Let's talk about phases of rehab. Yeah. Which is quite difficult, because I think it will depend on each client or each patient, because the symptoms, the severity and the irritability of symptoms might make the physio start from a very low level of exercising. And sometimes if the severity irritability is slightly lower, we can start with a slightly higher level. What are the key elements of rehab that you always start with in the first 2 or 3 weeks, Juan?
Well, in the first 2 or 3 weeks, your goal is to minimize the strain.
Yeah.
And to start the collaboration of the three abdominal layers. You want them to work in symphony together. Quite frankly, one of the best prescriptions you can give a patient with this is yoga or Pilates.
Yeah.
If more people did Pilates or yoga, we will have less of these patients.
Yeah.
They need control. Now, the area is already irritated. So if we strain these 2 layers that are shifted even more, they'll get more shifted. That's not what we want. We want them to come back together and work together, because even though they are 3 different abdominal muscles, they do work in conjunction. They must work in conjunction. So the first 2 or 3 weeks is telling the patient mostly what not to do. Don't get in a hurry. Don't strain it. You will get faster. You will get better faster if you back off a little bit, and if you use taping or some sort of compressive device for the area. I don't want them off sports, but I do want them not to strain the area.
Yeah. So any low level control exercises, like tiny hip control from crook line, or things like hip flexion and rotation from sitting, slow and controlled, could be just enough. So because it's not going to strain the muscle, but at the same time it will start the process of control.
That's correct. And you can even shift it to planks.
Yes.
You can go to planks and have them just do the plank.
Yeah.
Or as they get better, they can start doing a plank and going into unilateral hip abduction and adduction.
Yeah.
Now, it is very important, particularly with teenagers who are fanatic by nature,
Yeah.
to explain to them, don't force it. Doing it better, sustaining the pain is not a good idea here, because if you're having pain, that means that the strain of the wall continues. That's not going to get you back. You must do as much as you can without pain. In this case, it's very important to make that point, because otherwise people want to try, they want to get better, they want to get back. And it is particularly true with soldiers. You have to get it into their head that suffering is a bad idea in this case.
Yeah. So that's a great news for you guys, for everyone listening to us, because it's not about the exercise. It's all about any exercise you will choose that will activate the abdominal layers and regain the hip control will work. According to the patient tolerance, you can go with something very easy, or you can progress according to the patient ability. So single leg activities, most of the literature, they focus a lot on single leg activities, because logically this problem always is unilateral problem, right? And any kind of unilateral loading, which happened during single leg stance, for example, can aggravate the symptoms. And that's why it's highly important, very important, to regain control during single leg activities. Any comments on that one?
Two things on that. First of all, even though it's almost always a one-sided problem, when you brace it, when you tape it, you must do it on both sides or it doesn't work.
Yeah.
Don't just tape the one side. And many times you have to deal with putting some sort of petroleum-based cream on the skin, because the lower abdominal skin doesn't get exposed very often to light, and so it's sensitive, and the glue of the tape can cause a dermatitis.
Yeah.
If that happens, you have to back off for a day or so, but you must tape it on both sides. The exercises, the single-legged exercises, are a progression of the planks and things that are bilateral. They are better for this condition, but the patient must be able to do them without pain. They must be able to handle them. So don't start with those. Use those for later, because they will be better exercises than the planks, and they will really recruit the abdominal wall bilaterally and as a stabilizer, which is what they do. The abdominal wall stabilizes.
Yeah. So we might start with single leg activities in unloaded position, like bridging exercise, unilateral bridging, for example, which could be an easy one. And we can increase the repetition if needed. And then we can later on, according to the patient tolerance, we can progress to loaded, where activities like single leg squat, which, to be honest, I always recommend that I do this at the far end of the rehab, because doing squat and lunges, there is a massive amount of loading, and I need to progress very carefully to these two exercises. Now, let's move, and I'm sure some people during the question and answer will ask about the taping and how do we do it, and then we'll leave this to the question and answer then. The decision in terms of return to training, I'm not saying here return to sport, because it's something, there's a very late stage here. But when would you say, you are ready to do some walking, jogging, or even running? Are there any criteria that you use?
Yeah, the main criteria is without pain, because if it causes pain, it means that it continues to be strained. If it continues to be strained, it won't heal. They can return to sports the day after, almost immediately. But in these cases, you must work together as a team with the physical training or the coach and the athlete. The three of you have to be on the same page, or it doesn't work. In fact, athletic trainers can be a very, very important ally in the recuperation of these athletes.
Yeah.
Because the fact that they can go back with restrictions eases down the tension on the athlete, lowers down the anxiety, and makes them more compliant. Going back to sports will increase their blood pressure, will increase their pulse, will increase the oxygen and the nutrients to the area, so they will heal faster. All the restrictions that we give them must be specific, like, I want you to not serve tennis. You can go hit balls, but no service. And I want you to not do that for 2 weeks. They must have an expiration date. People can handle specific restrictions with an expiration date. They don't like to be told, don't do things. And in fact, it's not necessary. So you work in conjunction. I send them back to activity the day after, but I speak with a coach, athletic trainer, yogi, whomever, and I talk to them and I say, we're going to work together on this, and I'll give you some restrictions, maybe 15 or 20% of things you can't do, but you may do the rest.
Yeah, and we might use some outcome measures that and patients really like outcome measures, and because athletes are intellectually and cognitively, they are quite good, and they can understand the instructions, and because they have the motivation to go back to sport, they will hopefully, not all of them, but most of them, they will stick to the advices. So common outcome measures could be, again, you can look at the speed, you can look at the distance of running or walking even, but I would say going back to specific functional or sports related or sports specific activity, this is something, as you said, it has to be a teamwork between all the members, including physios, coach, athletic trainer, and the patient himself or herself. So when would you say, no, we need to refer you for surgery? 6 weeks or 8 weeks of good rehab, everything is fine, everything is promising, but after the first full training session, the pain came back again. Is it something that make you worried, or you would say, no, we'll carry on for another few weeks?
If someone has 6 good weeks of therapy and I think they're good and they think they're good and I send them back and they tear again, either I miss it or something is very wrong.
Yeah.
In either case, I've missed it. I think that the people that go for surgery are not the lower level athletes. The ones who go for surgery are typically the professional ones, are typically the ones who have a deadline. I have to compete in Tokyo in July, and they don't have the time to stay with me for 6 weeks and not be able to go back really hard at it. So generally, the surgical cases are not the ones who fail. Somebody my age would probably not fail because I don't have the level of strain necessary to fail. The professionals won't do. Professional football players do, professional track and field athletes do, professional gymnasts do. And in general, there isn't, if you do it right, there's not much of a rate of failure really with 95 or more % of the population. It's the other little group, the top 1%, the one that may require surgery because no matter how good you do it, you won't be able to get it to the level of strain that they have.
Yeah, yeah. And when we refer for surgery, I think the post-surgical rehab will be slightly challenging, but to be honest, will be more straightforward. Yeah, because you know that there is some sort of structural correction inside, and now you have more freedom of choices in terms of exercises, and also you have this sort sometimes. It's not all the time, because sometimes the surgery could fail. You will have this sort of peace of mind that the tissues inside are okay, are intact, and now you can start your rehab in a progressive and structured manner without worry. What's your comment?
Well, with the surgery, many times they use a mesh. So the area is going to end up being very strong, very stable once the healing biological process is done. So the decision for surgery has to do with typically with a date. We have a time limit. We're going to the Olympic Games, or we're going to the European Cup, or we're going to, we have a function. You have a professional ballet dancer, and she or he has to dance, and the company is going to start this new performance in January, and they have to be there for January, or else they'll be passed up. In general, it has to do with a date and a socio-economical problem. Not problem, issue, a reality. This person makes money with this, and they may not have the luxury of taking 6 months off.
Yeah. So that's mean we have other factors that will control our decision, and sometimes it's not an ideal world, but at least we'll do our professional duty and we'll give our patient enough information to make him or her able to make a decision. And by the end of the day, we are always here to help, but we can't fix everything. Yeah. So
on that note, don't think that because your patient ends up in surgery, you fail. In fact, that may not be the case at all. If that patient was a surgical case and you send them to surgery, you didn't fail. You simply steer them up in the right direction. It's like Feynman used to say, if let's say that I say that this shirt is blue and I do an experiment and it turns out not to be blue, I succeeded at proving that it was not blue.
Yeah.
This is the same thing. If your patient is surgical and you send them for surgery, you didn't fail. You took them to the appropriate professional that that patient needed.
Yeah. And we as a physios, we must be brave. And braveness has two sides. One side is, yes, I can do it. I will try everything I can with this patient. But also sometimes one aspect of being brave is to say, no, I need to send this patient for somebody else because he might get benefit from another professional. So being brave not necessarily mean taking high risk. No, it means taking the right decision on the right time for the right patient. And here comes the clinical experience that definitely helps this kind of decision making process. So a quick summary for everyone, guys. We talked about subjective examination. We give a general background about the problem, athletic pubalgia. We talked about physical examination. We talked about differential diagnosis, and we talked about other problems that might give slightly similar symptoms to athletic pubalgia. And then we talked about clinical examination and physical examination to be more specific. And then we'll move to rehab, either conservative rehab or post-surgical rehab. So generally speaking, Juan, if we would like to compare and contrast between conservative rehab and post-surgical rehab, you would say the main themes are the same, but the application of the rehab phases or the elements of rehab might be slightly different.
Yeah, the funny thing in these cases is that surgical rehabilitation is easier.
Yes.
Because you don't have the pain and you don't have anything pulling in the wrong way. It's solved. The base problem is solved. And now all you have to do is coordinate things with the athletic trainer and with the coach and get the patient back into shape. In fact, at times, surgical rehab will take less time than the conservative one.
Yeah. And also we have the mental peace of mind, because the individual or the patient, he knows that or she knows that I had something fixed. So for him or her, it's just a matter of time and matter of listening to the advices from physio or coach or athletic or the physical trainer. So I think these are the main things that we wanted to discuss. In terms of outcome measures, I think we'll have specific outcome measures related to control around the hip and core area. We have the range of movement, which is not a big deal, but also we might have quite functional outcome measures, and there is plenty of them. There is plenty of them out there, but I have a little issue with outcome measures. I always feel that for each patient, we can't use an outcome measure, a generic outcome measure for each specific athlete. Because from my point of view, each athlete is different based on the sport he's playing, based on the level he's playing. So we might need to modify some of the available outcome measures to fit our client. Do you agree, or are you happy with the specific outcome measures that you always use?
Well, no, in fact, in the US, if you don't present an outcome measure on evaluation and a discharge, they won't pay you.
Yeah.
And I think that's a good idea. You must use outcome measures that have the options. For instance, the one that I use, you can do it for orthopedic cases, neurological cases, cardiovascular cases. And then if you go into the orthopedic one, it breaks it down by sections of the body. And then it goes on through surgical and non-surgical. And then it tells you the different types of syndromes. So certainly you can't use the same, you can use the same outcome measure for someone who's 20 as someone who's 60, but you can't use the same parameters. So the outcome measure must be adapted to the patient. In fact, how do you evaluate someone? Well, who do you have in front?
Yeah.
When it's like when people talk about Mackenzie versus Mulligan versus Maitland versus somebody else, which one is better? Well, it's the wrong question. It's not better. It's which syndrome do you have in front? If you're looking for truth, go watch the sunset in the ocean or watch children play. You're not going to find truth in science. In science, we're boring. We are into experimental results, not truth.
Yeah, yeah, exactly. And also very important point, when we talk about outcome measures, we need to think about the term recovery, because the term recovery has a completely different interpretation for each patient. So if I'm a patient with a very acute disc bulge, and I came to Juan today to for a treatment, and I was actually limping and I was in too much pain, I can't walk, and you managed to give me less pain, and I managed to walk out from the clinic, for me, that's 70% recovery at this stage. Yeah, because I was in a very big trouble here, too much pain, I can't walk, very acute problem, and I managed to walk again with less pain. This is a meaning of recovery. But for Lionel Messi, recovery means I have to score 100 goals per season. Otherwise, I still have a problem. So I think we definitely need to consider outcome measures, and also need to consider the patient objectives and match them together. Yeah.
Yes, yeah, you must understand the patient's demands and what it means to be rehab. You said it very well. What Messi needs to be rehab is very different than what I need. I will be done very quickly because my demands are not that bad, that high.
Yeah. So I'm sure the questions from our colleagues will add more value to the session. We covered the main important points that we agreed to cover, and now we can move to our colleagues' questions. So if you guys just give me 1 second, we need to sort this out so we can allow you to start raising hand. Just 1 second. All right. So any questions, guys? So you might need to raise hand. And how can you do that? I will tell you in a second. If you are not familiar with Zoom, on chat, so guys, I'm now allowing all of you guys to unmute yourselves. So please don't unmute yourself unless you have a question, right? Okay. So anyone would like to start? So we have a question here about, is there a website or reference to read about this object? Yes. On PRIMEPHYSIO.com, there is a reference list, and also we can make it available to you guys. Yeah, there's a very important reference that I'm going to send to you at the end of the session through the chat room. Anything you recommend? Anything extra you recommend, Juan?
No.
No. Okay. So we have things to we have a range of references for you guys. Again, if you would like. Okay. So if you have a question, just raise your hand, guys. Okay, someone has a question. In your assessment, you talked about ruling out lumbar spine. Would you assess sacroiliac joint as well? And how would you interpret findings? That's a nice question. Juan, can you? Okay, just 1 second. Let's see that.
All right. Now,
Yeah, go ahead.
will I assess sacroiliac joint? No, not in this case. And the reason is because the sacroiliac joint is not capable of referring really pain into the pubic area. If somebody has a sacroiliac joint that is bad enough to create a pubic shift, well, that patient is probably after an accident or something rather violent. But no, I will be clear enough with the lumbar spine.
Yeah, definitely lumbar spine, and we have different things we can do. PA, we can do repeated movement testing to include or exclude lumbar spine, and also, guys, there is some recommendation about obturator nerve tension test to assess if the obturator nerve is interrupted or irritated, and in this case, if it does, we might include some neural gliding. Other question, what about what about muscle sling in rehabilitation to control both abdominal and hip movement?
I would use a sling or taping for the abdominal wall, yes, and that works very, very well and very effectively to allow people to take off some tension so the shift will not continue, the separation of tendons will not continue, and so that they can continue, begin to glue up together and work in unison.
Yes. Next one. Okay. Are there different programs related to specific surgery? I would answer this question, and then you can add, Juan, if you wish. Not really, because most of them, it all depends. If I'm talking about 10 years ago, it was more sophisticated surgeries, which might require some patient and wait for the healing to occur. But these days is not, most of the surgeries are microscopic. So we are not expecting massive interruption to the tissues. So no, I couldn't say there's a massive difference between different protocols of surgeries in terms of rehab. Any comments, Juan?
No, I agree with that. It's getting easier, and this is why we must be familiar with the surgical procedures and the tools, not because we're going to do it, but because surgical tools are better now, there's less disruption and recuperation is better. And also, there's a question that I want to talk quickly about. What if you have a young football player who feels better and then they want to go back? Well, you have to talk to the kid and you have to talk to the coach and explain, and let the coaches know that you're on their side, and let the kid know that you're on their side, and explain to them that yes, you feel better, but you're not done. It takes some time for healing. Kids don't like to wait, but they're children, and explain it that way.
Yeah. Next one, why we should exclude adductor strain or tear, and what about combination with osteitis purpose?
We should exclude it for two reasons. It may be that you have both, and if you have both, you have to treat both. And it's important to exclude it to know that you're not treating the wrong area. So if somebody has an adductor strain and you treat them for pubalgia, they're not going to get better. Adductor strains are as common as pubalgia, I think more common really. And so we must know that we're not dealing with that. And with osteitis pubis, if you have pubalgia, osteitis pubis will probably be present. This is part of the ruling out in the diagnosis. You must check to see if there is tenderness in the pubic area. Tenderness in the pubic area is very much leaning towards pubalgia, not an adductor strain. So it's very possible that you will have osteitis pubis with pubalgia.
Yeah, yeah. And that's why, from the orthopedic medical point of view, they use an X-ray to look at the pubic area, symphysis pubis, and if there's any kind of degeneration or separation, they might consider this as element of diagnosis for athletic pubalgia. Next one, what about what FAI syndrome management? I think this is outside the scope of this discussion. But to be honest, there's a lot of similarities between fibuloacetabular injuries in terms of control. Again, it's all about control. So let's move to the next one. During rehab, when do you think we should introduce high threshold exercise with low threshold exercise, and later in rehab, should we combine both? That's quite a clever question. What do you think?
Well, you start with the low level threshold. The threshold is marked by pain. You can do as much as possible without pain. And then you must back off a little bit. And then as the patient integrates the coordination of the abdominal wall better, then you can have them do things that are more complex, more challenging, and more functional, particularly when it comes to sports application.
Yeah. So, okay. Now, Muhammad Salama, I see the mobility of sacroiliac joint and its restriction will affect the pelvis until is in turn will affect on aggravating or relieving and healing process. I'm not sure, to be honest, about Srj mobility, because Srj is a link between lumbar spine and hip. Yeah. So we do expect if your hip has limited movement, it can affect the Srj. But I wouldn't say limitation on the Srj mobility, which is very limited. Bear in mind, guys, that Srj is not designed for mobility that much. Yes, it does move, but it's a very tiny range in multiple dimensions. I wouldn't say it will be a key factor on the management here. But if you would like to do some mobilization, you must have a reason for that. What do you think, Juan?
The SI joint works not so much as a joint. It does have movement, but it's in the range of 1.5 degrees.
Yeah.
Average. It's a little more in 17, 18-year-olds. It's a lot less in me, but generally there's really not much movement. If somebody has had a trauma bad enough to undo or shift their SI joint, they may have a concomitant pubic distension, but those things are very painful, very obvious, and frankly, think of the SI joint as something that doesn't move, because for practical reasons, or unless you have a pregnant woman, they really don't.
Yeah, yeah. So the answer in this case, we can't say Srj mobility could be an issue here. So let's just focus more on control, because this problem is mainly a control problem, guys, rather than mobility problems. Yes, mobility is an element, but it's mainly on the hip joint, which is a highly mobile joint. Next question from Ahmed Rabia. Ahmed, I will unmute you so you can mention your question by yourself if you wish. Can you hear me?
Yes.
Go ahead, Ahmed.
If he if he has some pain during the exercise, and I say it's wrong, don't do that. It will give him a wrong message about central sensitization. He will avoid this movement, which will affect him on SAS.
Yeah. So if I manage to hear you well, if you don't mind, Juan. So I think the question here about we made it clear that we need to avoid pain during rehab. And Ahmed has an interesting question here about if we ask the patient, don't do the rehab, do the exercise without having pain, we are sending the wrong message in terms of the pain belief, right? Which might add to central sensitization. I think it's a different scenario here, Ahmed, because we definitely must avoid pain, because pain means there's some sort of structural deficit and we are not allowing enough time for healing of the tissues and in order to regain control. So yes, I do agree. If you look at other conditions, other musculoskeletal conditions in particular, like joint problem or nerve problem or tendon problem, you might need to emphasize the fact that pain is not a threat and it's still okay for the patient to feel pain. But this scenario is different, Ahmed, I think, because we are avoiding pain in order to make sure that the patient have time for healing and then have enough time to regain control. Would like to add to that one?
No, I agree. In this case, the idea of avoiding pain is explaining to them that we don't want the tissues to get any more strained than they have, and they will heal, and emphasize that they will heal. I don't think that there will be enough time in these cases for central sensitization, and the pain is very intermittent. It hurts when you strain it, and it stops hurting when you don't. So
Yeah.
there wouldn't be a case of chronicity in that sense. It's a good point, though.
Yeah. Next question from Kinan. Can I use a traffic light system in exercises regarding pain in pubalgia and first stage of rehab, or the pain should be 100% free?
Well, you can use a traffic system. It's just that, remember, when you're dealing with athletes and teenagers, they want to do more than they should. So sometimes you have to put the reins a little tighter. We don't want to strain it, because if you continue straining it, it will take longer to heal. It will heal, but it will take longer. So in these cases, you have to go a little bit from the green to the red. Don't give them much of a midway, because without bad intentions, they will probably abuse it.
Yeah, yeah. Other question from our colleague Sander Mais about non-steroid anti-inflammatories and painkillers. And is it recommended or not?
You can use them a little bit, but frankly, in these cases, I want them to hurt when they're hurting.
Yeah.
It sounds static, but it's not. I would rather them not use so many anti-inflammatories. If they're going to use them for the first week, fine. In fact, I tell them, if you're not going to take them for 4 days, don't even bother, because you won't have enough drug in blood. But perhaps use them for the first week. After that, I will wean them off for 2 reasons. The inflammation will be controlled, and I want the pain to be a safety guard. I want it to act as a defense mechanism that will stop him and I.
Yeah. So definitely with these cases, I will not consider painkillers or medication, because to be honest, they are not going to make any kind of changes in the structural problem. Number one, and number two, as you said, Juan, we need to feel the pain, because pain is our alarming mechanism, and we need this kind of alarming mechanism to be active all the time. Okay, electrotherapy modalities and conservative management in these cases. Good question. From my point, I'm talking about myself here, and I'm a little bit biased. I think electrotherapy modalities is not going to make a massive difference, because we are talking about athletes. Okay, let's think about what kind of electrotherapy or electrophysical agent can help here. I would say anything that can give some sort of support. Taping, and taping is not an electrophysical agent. Yes, I will use it, because it can give some sort of proprioceptive input. And but other physical modalities, I'm not a big fan of any, unless you have a reason. My colleague Pratik. I will unmute you, Pratik, if you wish. Pratik, you are now unmuted.
I think
in acute cases, mainly when he has acute pain,
yeah,
that time, is it possible to give some kind of electrotherapy modality to reduce the inflammation and also the pain, so that we can put him on rehabilitation exercises?
Any specific electrophysical modalities do you you're thinking of, Pratik?
I'm thinking, would ultrasound be of any effect?
Ultrasound. I didn't come across any evidence for using ultrasound for such scenarios, but I would be quite reluctant to use ultrasound in this area because we have vascular tissues. It's quite close to them, very sensitive tissues. So, but I wouldn't say yes, I wouldn't say no, but I will question the benefit of using ultrasound in such scenario. What's your comment, Juan?
I think that the idea of ultrasound, it's interesting. It would be nice to increase the blood flow to the area, but like Mohammed said, there are many other tissues that you have to be careful. I will be more willing to use, for example, electrical stimulation in not in the first stages, but in the later stages to get a stronger contraction and to really recruit the musculature. But there are very many novel structures in the area, and the ultrasound will hit them all, unless you use a 3.3 megahertz one and be very careful.
Yeah. Any more? Are you okay with this answer, Pratik?
Yeah. He said electrical stimulation. So will it be TENS that he is referring to, or electrical stimulation like the electrical current that we are talking about?
I didn't hear.
Can you repeat again, please, Pratik?
You said Mr. Juan said that he would put him on electrical stimulation. Does that what he was referring to? Was he referring to TENS as an electrical modality, or is there any other modality that you're referring to?
Oh, I will go more for something like a Russian stimulation to contract the muscle, not so much for pain control, but for contraction in the later stages, get a stronger contraction of the abdominal wall.
Okay, so in acute condition, suppose he comes with an acute pain, what is the protocol that you would follow?
I will work without pain, and I will probably tape him and control the movement and the contractions of the lower extremity in space, so that they will not create a torque in the abdominal wall.
Okay, thank you so much.
You're welcome. All right. Any more questions, guys? All right, Muhammad Salama, let me unmute you. Muhammad, you're already unmuted, so you can go ahead with your question.
Okay.
Yeah, go ahead.
So after regaining the control, retraining for and motor control on this region, Mr. Juan say we can go ahead with high threshold exercise, but which can I consider in my rehabilitation program? Endurance more or power? Which
Good
component?
question. The answer is yes. You go for both. You go for strength and endurance, but in the case of this type of muscles that are stabilizers, endurance is more important. Generally, the abdominal wall, it's holding the trunk so that the lower extremities can move in space. There are some cases where they work a lot, like say in the serve of tennis or in the throwing of a javelin, the service in a spike in volleyball. But as a general rule, you need more endurance in this musculature than strength. And it is when they fatigue that they get hurt, because they can no longer contract, hence protect the area.
And I would say endurance exercises have actually a double effect. We know that exercise considered as a pain relief, number one. B, endurance, if you do control exercise, which is mainly done by slow controlled movement, which is under the umbrella of the term endurance, you will get this kind of required function for this part of the body, which is the core area. So, but at later stage, maybe before you make a decision about returning to training or returning to sport, here comes the role of drills, the role of acceleration exercises, which has some sort of strength component. Definitely strengthening the adductor is quite important here. And I'm sure everyone heard about the Copenhagen protocol or Copenhagen exercise for adductor, which is a combination of eccentric and isometric control. It also could be used. So the term endurance is definitely applicable here, and we need it. But at some stage, we definitely need to focus on strength.
Yeah, and speaking of things,
go ahead.
One important thing right now we have all this fade of core. Everybody's doing core. And they talk about core as an abdominal exercise, or they talk about core as a lumbar exercise, or a combination of both. In reality, core is the ability to maintain intra-abdominal pressure under stress. So for core and for pubalgia, the rehab exercises involve, of course, the abdominal area, but they are in conjunction with the groin muscles, with the perineal muscles. You need the whole area to be contracting together so that later on, when the patient goes back to athletic activity, that area is controlled and it is contained during stress, during the increase of abdominal pressure.
Yeah, definitely. So next question from Meret Maher. Which muscles in the abdominal wall? Meret, I can't find you, so that's why I couldn't unmute you. So sorry for that. But I will say the question out loud. Which muscle in the abdominal wall do you need to target for electrical stimulation for a stronger contraction? Okay. This question is not for me because I don't use electrical stimulation, to be honest. But Juan, if you...
Yeah, you will target them all, actually. It would be nice to be able to target them separately, but in truth, you want them to work in conjunction, yes, and you wouldn't be able to target them separately. You might hit the oblique on the sides because there's less mass there, and perhaps you can recruit better the transversus abdominis. But the truth of the matter is that you will recruit them all, and you must do it bilaterally. Remember, this is very important in pubalgia. Work them bilaterally because doing it on one side, it doesn't really help.
Yeah. So I'm just aware of time. So this will be, we'll take this question, and if you have one more question and that's it. Our pelvic floor exercise and mobility can help on this case. As we mentioned, mobility is very important, particularly for the hip joint. Pelvic floor, definitely yes. I would say definitely yes, because this problem is related to the pelvic area, and regaining control of the pelvic muscles, pelvic floor muscles, definitely will improve the control around the area, and hence will decrease any kind of overloading of the abdominal layer. Any comments, Juan?
No, it's true. Definitely, you need the combination of musculature in the area. Yes.
Yeah. Next question: what's the absolute contraindication exercises should be avoided after surgery? I would say any exercises that will interfere with the surgery, or any exercise that will be too much for this patient at this stage, and maybe things that include too much weight bearing, excessive loading. But again, you must be clear about when. Are you talking about first week, or are you talking about 6 weeks? So any specific contraindication?
I mean, initially you will avoid the extreme ranges of lumbar extension.
Yeah.
And you will find that in gymnasts, you will find that in yogis, and you will also avoid things that increase the abdominal pressure significantly, like squats with a lot of weight. Now, the patient can do squats rather quickly, but they shouldn't go beyond 80% of the maximum at the beginning.
Yeah.
The surgeon actually will give you those restrictions.
Yeah. So it will be surgery specific. So we are going to follow some sort of protocol that will be decided by the surgeon, which is not a problem. Because this is his job and he has to protect his job. What's your comment about pectineus muscle involvement in pubalgia in athletes? This is from Kenan. So I'm trying to unmute Kenan. So I need to get his idea about why pectineus in particular he's more concerned. Yeah, Kenan. Kenan, you now are unmuted. Kenan? Yes? Kenan? Mic is not working. Okay. Yeah, all right. So the question about pectineus, I'm not aware of any specific recommendation for pectineus, but it will be considered as part of the adductor group anyway.
Yes, I don't use any specific ones. I use them in combination with the adductor, and really you strengthen the lower abdominal wall in combination with the adductor growing masses and the perineal area.
Yeah. Okay. Another question about factors to be considered to return to sport. I think we mentioned this point, but we can recap this point quickly again. Go ahead, Juan, because I already talked about it later on. Go ahead.
Return to sports, depending on the level of the athletes, it's 6 to 12 weeks. And to full sports, they can return to sport almost immediately when they're non-surgical and 2 weeks after surgery with restrictions. But when it comes to full sports, unrestricted things, it's 6 to 12 weeks. And that is very variable because there's a big difference between 6 and 12. But they must understand that they have to go back healed. If they haven't healed, they will break again. Yeah. And it will probably be worse than the first time. People get anxious. That's normal. It's understandable. It's good, actually, that they want to come back. But you must explain to them that biology is biology. We cannot make biology any faster than it is. We are superior mammals. We heal at the rate we heal. And like I said before, the difference between somebody young and somebody older is that somebody young will heal in 40 days, somebody older might heal in 45, and somebody who's older but was a professional athlete will heal in 42. But nobody heals in half the time. And we must be very good at explaining that and teaching that to people so that they will see that at times backing off is your fastest way back.
Yeah. Mr. Juan, you just mentioned that the athlete can go back with some restrictions. So are there any precautions that he's supposed to take while he is returning back to sports with restrictions?
Yes. You talk to them about the pain, and you tell them to avoid extension of the abdominal wall. For example, they might go jogging, but not sprinting, because if they sprint, they're going to push back their hip, and that's going to create a lot of torque in the abdominal area. They might play tennis, but not serve. They might play volleyball, but not spike. Things like that. You basically go with avoiding movements that will create the most torque until the healing is done.
Yeah.
Thank you very much.
All right. Thanks, Pratik. So I think this could be the end of this nice session. Juan, I really enjoyed this session. Thank you so much for your sharing your clinical experience with us. And thank you everyone for joining us and staying that late. As I said, the session is recorded and it will be available for everyone to watch. So please let your colleagues, let your friends know about it. It will be available on YouTube, PRIMEPHYSIO UK, YouTube and Facebook page. So thank you, Juan, again, and hopefully things will settle down soon, and we'll see each other face to face at some point. I'm not sure when and where, but hopefully this will happen in the near future. And thank you, everyone, for your contribution. And good night. Thanks, Juan. Bye.